morning, everybody. This is Sue Birch. It is May 12th, 2022. We are recording this meeting. I would like to call this meeting to order. And there's the virtual gavel. I always do that for Connie. It's a little joke for the two of us. Welcome. I hope everybody is doing well, staying warm. I want to remind everybody that due to COVID-19 and the Governor's Proclamation 20-28, we are meeting today via Zoom only. Dave's going to give us a little bit of an update about the Open Public Meetings Act and some of the changes in his portion of the meeting. First, I'd like to do board member introductions, and I'm going to do a roll call to identify board members with us today. So board members, if you'll come off mute as I call your name. Elliot Weinstein. We see you. We're
She's on mute.
Okay, I couldn't unmute. Yes, I'm here, obviously.
Thank you. Tom McRobert.
Present.
Thank you. Harry Bossy.
Present.
Great. John Comerford.
We don't see John at this point yet, so we're checking on him too. Staff
will alert me and I'll announce that when he joins us. Scott Nicholson.
Good morning.
Thank you, Scott. And Leanne Kunze. Is Leanne joined us just yet?
Not yet. She does have a login issue and we're working with her on it.
Okay, so for the public, we are anticipating one of our voting members to join us, and John Comerford also as well. Also, Michael Tunick from the Attorney General's office. I believe, Michael, you checked in earlier. I see you there.
I'm here. Yes. Thank you, Chair Birch.
Thank you, Michael, for joining us today. And I'm Sue Birch, and I'm chairing this meeting. So with board members and presenters attending virtually, it'd be helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members, both myself, Dave, Connie, the command room, we'll be watching in case you use the Zoom raise hand feature to indicate if you have a question. If for some reason we don't see you, then you can jump in, but please try to signal either with the electronic hand signal or your hand. For the public, you're going to have an opportunity to provide general comments at the end of the meeting during the public comment period. And again, we will be calling that out and recognizing you. So at this point, I'd like Dave Eisminger to provide us an overview of today's agenda. And Dave, over to you.
All right, good morning, Chair Birch, members of the board. Dave Eisminger for the record. For the public portion of our meeting, we'll kick off and continue our conversation about potential dental benefit design options, knowing that you've had an additional month to reflect on the general concepts that have been presented at the prior two board meetings. We also want to share the nature of the sub-board conversation with you, just as we shared the nature of your conversation with the sub-board. Then we're going to have a presentation about vision benefits and a survey that the agency ran earlier this year to get a better sense of, as we look at potential benefit design conversations on the vision benefit as well. Then we have a series of updates that inherently relate to upcoming procurements that the agency is running that we want to keep you informed about. One related to our tax advantaged accounts, that's the flexible spending account, Spending Care Assistance Program, those types of accounts, and then a wellness smart health update, which also includes an upcoming procurement that is planned by the agency. We like to keep you apprised of procurements, even if they aren't ones that you have a direct control over or influence specifically of that procurement. We like to give you an update on some of the major initiatives that relate to the program, regardless of how it relates exactly to this board's authority. Then we will transition to an executive session and have a lengthy discussion in the executive session about some topics as it relates to the rate negotiation process, which eventually will be part of the public meetings as we head into June and July. The other piece that I wanted to highlight is for staff that are presenting today, I would like to highlight the background the agency will be using. The background that you see will be the Vantage Crossing between Kentapath and Grant County on the Columbia River. Very scenic part of our state, just again, as we enjoy the natural beauty of our state during our virtual meetings. And then last but not least, speaking of virtual meetings, I wanted to give a little bit of an update on where we are on the structure of our meetings, the pandemic, the Open Public Meetings Act, and all the various legal authorities that kind of relate to this topic. Now, we originally thought, and in fact, at last week's subboard meeting, I previewed that we were intending to transition to hybrid meetings where there would be a physical space here at HCA and Olympia for both board members and the public to attend if they wanted in early June. However, in the last week, we've learned a bit more about the regulatory environment, which is quite complex, and that there is the ability to continue with fully remote meetings at this point. And most importantly, we're focused on everyone's safety as much as possible. And knowing that COVID infection rates are currently actually on the rise again with yet another new infectious variant, our recommendation is going to be to continue fully remote meetings, except for Connie, Jessica, and I here in the command center, like we've been doing the entire pandemic, at least for the time being. And I wanted to see if there were any concerns about that approach, because that's the recommendation of the agency at this point, at least as it stands for June, and we'll just keep evaluating. The agency supports 13 different entities that are part of the Open Public Meetings Act, and we're trying to make the same recommendation throughout all of the entities that we serve, thinking about, or administratively support, thinking about the complexity and again, all important safety of both you, us, and the public. So that is our recommendation. I want to see if there's any questions or concerns, because we will continue on with virtual meetings, at least for the time being, and visit this topic as more information becomes available or circumstances change.
Thank you,
That's
Dave.
what I have.
Thank you, Dave. I certainly think that it is wise to endorse staff recommendation and for us to maintain this fully remote type of meeting structure until we have further information, because it truly is a little more complicated with all the data coming in and the technology needs. So I don't think we should disrupt or change anything at this time till we get further guidance. Is the board, I see a lot of heads shaking that there's agreement. So Dave, I think you've heard now from the board that we concur with your recommendation. And as we know more, we'll revisit this decision in the future. So at this time,
I do realize that I'm next on the agenda with a follow-up item.
I was just going to say, Dave, take us into our next agenda item, the follow-up from the April 14th meeting.
Yes, I didn't realize I have one more topic. So last month's meeting, most of the questions related in the dental presentation that Ellen was providing, and she has follow-up on, should be able to address the questions that were brought up in her presentation. The only other question that really came up was Scott Nicholson requested a demo of PEB My Account, and we are planning one for him. I realized that when we did a demo for the board last time publicly, I don't think he was a board member yet, so we'll do a demo with him, but it made me think, as we get closer into the launch of that, which is now set for next spring instead of this spring, that we would bring back an overall presentation and demonstration to the board next board season as well. So we'll do a presentation for Scott, but I did want to also just let the board know that we'll do a refresher for everyone as we get a little bit further and closer to the launch date of spring of 2023 at this point. So just didn't want anybody to feel left out, but I realized that that's probably why Scott needed or wanted a demonstration, but it'll be a good refresher for everybody as we get into the next board season. So those are the follow-ups, and like I said, Ellen will cover the dental questions when we get to her presentation, which I think is next. Sue, back to you.
Great. Okay, so as Dave says, Ellen Wolfhagen is going to take us into our next agenda item. It's the 2024 Uniform Dental Plan Benefit Design Options. Ellen is our Senior Account Manager in the PEBB division, and she's going to follow up from the April meeting and review the design options that could lead to changes for 2024. Ellen, good morning and welcome.
Good morning, Chair Birch and members of the board. Thank you for your attention this morning. So this will be the last of my presentations this board season, but there's still time and we are getting feedback and input for the decision package. Next slide, please. I'm actually not seeing the slides.
I think something happened, Dave. We see the command room, but we don't see any posted slides.
Experiencing some technical difficulties. It'll just be one moment.
Everybody hang on. This is our virtual challenge. Well,
It went blank.
Ellen, thank you for waiting patiently. Okay, we're starting to see some screen sharing activity. Now we've got
Great,
slides.
thank you. Okay, next slide, please. So as Chair Birch said, today I'll do a follow-up from the April meeting. We'll go over the specific proposals again and provide relative financial impacts to guide the prioritization discussion. Next slide, please. So can you go back, please? I am going to answer questions from April. I do not have slides on everything, but I do want to give some answers to questions. So one of the questions was, do we recognize the savings? Can we provide data on the savings based on having preventive services? And according to Delta Dental, the cost increases every year that people don't have a preventive visit. If there are no visits in 2 consecutive years, there's about a $368 difference between the costs per member. So that answers that question. We do know also for children, children who have sealants, which is one of the preventive services that can be provided, see costs of about $127 less following that. Also, we were asked about information on the whole health risks associated with poor dental care. And we have information and we'll make this available through the various communications that we have. It may be something that we highlight in one of the newsletters. And there's obviously a connection with diabetes, stroke, heart disease, premature birth, and low birth weights that can be highlighted in dental news. And dental offices can sometimes address side effects from chemotherapy, which is another benefit that we can highlight. Thirdly, we were asked about composite fillings for baby teeth. Currently, there is no distinction. So we're talking about composite fillings in posterior baby teeth, so premolars, molars as they come in for children. There is no difference in the contract coverage right now for baby teeth, but obviously it has to be necessary to do a composite filling, and we can explore changes to that further if requested. And then finally, I was asked if we had some pre-pandemic data on people who did not have preventive visits. And this is a little bit counterintuitive. So stick with me a sec. Pre-pandemic, the number of people in PEB was fewer than it is now. So 261,381 total members. Of those, 61,381 did not have a dental visit. That's about 28%. But in 2021, which was a pandemic year, although we had an increase in total membership to 312,200, 73,162 members did not have a dental visit at all in that year. And that's only 23%. So we had a drop of about 5%. And I think this is just my thinking on this. Do not take this as anything other than that. But my thought is perhaps COVID drove people to sort of reevaluate the need for good overall preventive health. And so maybe people ended up having their dental visits. Next slide, please. Let me pause here and see if there's any questions about the answers that I provided before I move on. I see Elliot has her hand up.
Go ahead, Elliot.
I have to unmute. I'm sorry. I don't know how statistically valid this is, but in my area, several of the dental clinics had to shut down for a while because they had to sterilize and change. I don't understand the whole thing, but change the operatories, change everything to conform to the new requirements. So that backed up their calendar. I only know this because it affected me. And I go to the one for Panorama Senior City. So, okay.
Thank you for that comment. Others, questions from the board? It looks like you can proceed, Ellen.
Thank you. So one of the questions that was also asked was, what's the difference between the coverage for preferred providers and premier providers? Just as a reminder, preferred providers have the best contracted rate with Delta Dental, and therefore the coverage is higher. Premier providers cost more for both the member and the plan in terms of payment. So there's a difference in the coverage most significantly in Class 1 preventive services. Currently, premier providers are only covered at 80%. There are about 8,000 providers in the state of Washington. 3,800 of them are preferred providers and 4,200 are premier. I also want to note that the recommended change to the plan maximum covers preventive services at 100% for both preferred providers and premier providers. So it would do away with this difference on this slide. In Delta's book of business.
A question from Tom.
Yeah, this is just a very minor quibble, but you referred to, when you were talking, you referred to it as Delta Dental. And I think there's, and I mentioned this at our last meeting, there is some confusion between the Delta Dental plan that is a managed care versus the uniform dental, Delta Dental, that is not. And I'm wondering if we can't, and just to make sure that people don't get that confused in their heads, if there's some way that we could clarify that a little bit.
So Tom, thank you for that. We refer to the managed care plan as Delta Care. It is always referred to that way. Delta is the carrier, and their network has many plans, of which the Uniform Dental Plan is one. And when we talk about UDP, we are talking about the UDP Preferred Provider Organization Plan. And going forward, we're going to keep reinforcing that it's UDP PPO to help cement that difference. Thank you for pointing that out. In Delta's book of business, were there more questions? I'm sorry.
I don't see any other hands.
Okay. In the Delta book of business, we see more groups that keep the difference between premier providers and preferred providers, because that gives a benefit to the members and the plan itself in terms of payment. Next slide, please. So again, just to go over, these are the benefit proposals. These are in the order of the percentage of population that would be affected by them. The annual plan maximum adjustment, composite posterior fillings, then the incentive plan, no deductible for children's benefits, and TMJ. And I want to make a transition here to talk about crowns. When we met with the PEB board, They expressed great interest in improved crown coverage and asked us to do sort of a deep dive in what can be done with crown coverage. So I'd like to go into that now. Next slide, please. When we did a market comparison, we looked at crown coverage and found that for the most part, we are aligned with the Delta Book of Business. Crowns are usually covered as Class 3 and offer 50% coverage. WEA pre-PEBB, that's the Washington Education Association, had a very generous plan that covered crowns as Class 2, and therefore they were subject to the incentive plan, which ranged from 70% to 100%. So somebody coming new into that plan started at a 70% coverage, including their preventive services, which is lower than what we have always had in the UDP. But then based on preventive visits each year, they could move up, and they went to a maximum of 100% coverage. Next slide, please. So we looked at crown coverage and changing the percentage of coverage. PSPM is the per subscriber per month difference. And we looked at increasing to 60% for preferred providers, 70% for preferred providers, or 80% for preferred providers. At 80%, that would switch coverage to the Class 2 level. And you can see that the range of cost impact is from about $2.25 per month per subscriber up to more than $5.50 per month per subscriber. So when we look at that cost increase compared to all the other benefits that we talked about, those 5 options that were laid out before, the increase even by 10% to 60% for preferred coverage is more than any individual option that's been presented. 70% would be at the low cost of all 5 options combined, and an increase to 80% is higher even than, or is at the very high end of the cost for all options combined. So just something comparative to think about. Dave, did you have anything to add on this?
I think that we were trying to show relative because we'd already had the conversation and presented about the 5 options, the relative piece. So crown coverage is a rather expensive benefit enhancement for discussion. As we go a little bit later into the share with you about the SEB board's conversation about the benefit design, it's something that the SEB board has expressed a significant amount of interest in, and it is definitely one of the top things that we hear from school employees about the benefit design is the difference in coverage in SEB benefits, which are exactly the same as PEB benefits, compared to the dental benefits that they had prior to the SEB program. But it is, as Ellen has highlighted in the right-hand column here, it is an expensive benefit option, especially, and we tried to show a relative to the other pieces that we had already presented. Elliot, I see you have a question.
Yeah, I calculated the most expensive one. And let's say you're looking at a senior and we're self-pay for this. We would be self-pay, and it would be an addition of $66 per year, as I understand it, if you went with the highest option, and $27 per year if you went to 60%. What I'm looking at is, given the numbers that Ellen talked about in the savings and preventive cost, it might be something that seniors, since they're self-pay and there wouldn't be as much of a hit for employers in the budget, seniors would be interested in. They would, fork it over themselves, pay the cost, self-pay, and it wouldn't be as big of a hit on the budget. And it is something for seniors. I won't go into this too much because I love dental. It was my background. You have a lot of worn crowns. You have a lot of old amalgam crowns. You have stuff builds up over 40 years and stuff shatters. So it would be something, I believe, that retirees would be interested in.
So Elliot, just to clarify, because I want to make sure, you're thinking that many retirees may find $66 as the math that you did is kind of the rough estimate because there's, we still have a little more modeling, but that's the ballpark. You're saying that you think many retirees would find that annual amount an investment given the amount that crowns cost and the additional coverage that would happen. Am I understanding right?
That is correct. And I can only give my own experience. I had a UDP covered doctor and dentist, and it cost $650 for my crown. And that was last year.
Yeah, no, definitely appreciate your perspective on it because you're right that one of the key differences between the programs is there's the retiree population in the PEB program who is self-pay for this benefit. So that is an important reminder that when we talk about any benefit increases on the dental benefit, the ultimate premium increase for self-pays, which includes retiree and COBRA members and people on leave without pay, they would bear 100% of the premium cost, whereas the premium cost for employees in both programs is borne by the employer, and there is no dental premium paid by employees or school employees.
And the other thing, I'm sorry, go ahead.
Nope, that's a good reminder, Elliot, and the perspective about what that, $66-ish would be. Back to you, Elliot.
And the other thing that I want to point out is that the dental plan, correct me if I'm wrong, Dave, there's still some big holes in my knowledge. It's not mandatory that a senior elect dental coverage. And so they don't have to join if they don't want to.
That is correct. For retirees, dental is optional. For employees, it's a mandatory benefit, but there's no premium for employees where there is premium for retirees. But you're correct, it's a voluntary benefit for the retirees. All right, back to you, Ellen.
Thank you. So let's move into the prioritization discussion. And I just want to point out that, crowns is something that we are thinking about compared to, or in addition to, or instead of the other options. So just keep that in mind. Next slide, please. Next slide, please. So again, on the incentive plan, the composite fillings, and the annual plan maximum, and remember the annual plan maximum change is to cover preventive services at 100% for both preferred and premier providers, and not have preventive services count against the annual plan maximum. The annual plan maximum is the amount that the plan pays, not what the member pays out of pocket. So the premium impacts for each of these is between $1.25 and $2.25. And again, that's comparable to raising crowns to 60% coverage. For the state and SEB organizations from a budget funding perspective, because as Dave just pointed out, for employees, these are fully employer paid benefits. Any change individually would impact the funding rate. Dave, do you want to talk about the dollar amounts and the impact?
There are
The
two
translation
things I'm thinking
to
about in relation to which part, Ellen?
Sorry, the overall funding. So $1.25 and $2.25.
Yeah, I think I covered that on slide 11. I'll just take a moment, though, to highlight again that the upper range for these three proposals that we had presented prior prior to this meeting had that range up to about 225. And then the compare and contrast with the Crown slide from a few moments ago, that's where we were saying the individual cost of Crowns at just 60% is a higher incremental PSPM than any one of the three most expensive benefit design ideas that have been presented previously. So just wanted to tie that together a little bit, but I'll talk about the overall cost in about 2 slides.
Thank you. One of the things that we're trying to do is balance the impacts on the broadest percentage of the population with the ultimate costs. So those are factors that we are keeping in mind as well. Next slide, please. For TMJ and child deductible, and that's removing the child deductible for children up to age 15 on class 2 or class 3 or TMJ services. These two changes are very cost neutral, under 50 cents PSPM for SEB, under 25 cents PSPM for PEB, and that's combined for the two of them. So again, for the state and SEB organizations, either of these changes is unlikely to impact the funding rate. Next slide, please. This is where Dave is going to talk about the impact of the total package here. Dave?
Thanks, Ellen. And I apologize to the board if this is a bit repetitive. Given the number of conversations we have preparing for meetings, the number of stakeholders we talk with, 2 boards and a partridge in a pear tree, sometimes I honestly don't remember if I said something in a particular forum. So if this is a bit repetitive, hopefully it helps one more kernel of it stick. And if it's new for some reason, then it's new. It's interesting, the scopes and breadth and timing of our program. So an important part about the 5 benefit proposals, and then I'll onion layer on Crowns in a moment, is that if you combine all of the 5 proposals, you get a range of about 5 to 7 PSPM, and that's per program. So both in the PEB program and in the SEB program. If you look at the combined cost, when you extrapolate that out to state dollars that end up in the state budget, about $1 PSPM is roughly $1.5 million. It's a good proxy. It's not exactly that, and it differs just a little bit for both programs, but on average, $1 PSPM in the funding rate for the PEB and SEB programs is about $1.5 million. So when you take the $5 to $7 range, you multiply each of those endpoints by $1.5 million, and then multiply that by 2 because there's 2 programs, you end up that the package of all 5 proposals that were previously described hits that range of about $15 to $21 million. And so as some proxies, other things that cost $15 to $21 million or in that ballpark, the LTV conversation that we had for the last couple of cycles, where we discussed, and there was a decision package put forward to increase the employer-paid LTV benefit to $1,500 instead of $240 in PEB and $400 in SEB. To increase that to $1,500 for both programs fell in the same range. Another interesting benefit design idea that kind of circulates some is we all know that, or hopefully we all know that in the vision benefit, our hardware benefit is $150 every 2 years. As an interesting comparison point, a $50 increase in the hardware benefit, similar to this $15 to $21 million range. And so one of the reasons that we crafted different proposals for you, there's obviously different ways to look at annual plan maximum. The incentive-based design, there's dozens of ways that you could frame an incentive design. And we brought you very specific proposals on each of these with an eye towards hitting this $5 to $7 range, because in our experience, this might be a high-end tolerable amount for an incremental cost given different dynamics in the state budget on any given year. In no ways is there a guarantee that all of this could be included in a state budget. But beyond this point, it really becomes unlikely that the scope of a decision package would be fully supported. And I don't want to disillusion anyone into thinking that it's anything we guarantee that this is asked for, that it million, and you quickly get into the $10 million plus range for just crown coverage. So the point of our entire exercise and discussions over this now being the third board meeting, is to try to craft a proposal that we think has some tolerable moving parts, and ask both boards what your perspective is on the most important ideas, and if there are ideas that you really think should not really be heavily considered. But that's the big picture when we talk about the overall cost. And when I talk about the PSBM cost, that $15 to $20 million range, $21 million range, that is the cost to the state budget because of the employer paid premium in the PEB and SEP program. Again, the retirees are self-pay, voluntary benefit. That $15 to $21 million is not reflective at all of the retiree population. That's solely the state budget with the employer paid premium, 100% subsidy.
Dave, thank you for that.
Did I miss-
Dave, thank you for that summary. Elliot has her hand up.
Yes, I found that summary inspiring, frankly. I went and looked up the cost of the state budget this year is $64.1 billion. And the cost of a $21 million benefit would be, 0.03% of the total budget for 2022. So that kind of gives that another perspective. You inspired me to start delving into budgets. So the more you talk about this, the happier I am.
Well, and Elliot, just another interesting point, the PEB and SEP programs together represent somewhere around 9 to 10% of the annual budget expenditures for the state. The two programs combined are already around $5 billion annually. And so just another perspective about the budget. And every agency and every program has great ideas for how to improve things for Washingtonians. And so it's just important to remember that, if just the PEB and SEP program had 5 proposals that were each $20 million, that's $100 million just from one program. That's one part of one agency in the state. So there is an important, it's important to keep apart that context. And yes, it's a very small percentage of the state budget, this individual proposal, but it is among a sea of other competing policy ideas for the state.
And I would be remiss not to also note, and Yvonne, I'm channeling Yvonne, but I think we also learned in COVID the equity and disparity challenges. So I really appreciate, Dave, your perspective and your comments and how you summarized, Ellen, all of your work that you've done on this. But I think too, as a board, we have to constantly keep thinking about, parity and how do we push certainly between PEB and SEB. And then when I think about all other covered lives in the state and the other resources needed. So, and if we keep spending in the health and human service sector and crowd out environmental and economic issues, I just hope we can continue to take an evidence-based approach and be really thoughtful. Other comments or questions from board members? Ellen and David, doesn't look like there are any others.
Great, thank you,
Great.
Chair Birch.
Ellen has more slides, so back to Ellen.
Always more slides. So next slide, please. Just a reminder that some of the factors affecting these numbers are estimates only. And it's important to keep that in mind that they can change. They're based on 2021 pandemic period utilization, and premium increases may vary. And finally, it's important to keep in mind that the Uniform Dental Plan is a self-insured plan, which is different than the managed care plan. And as a self-insured plan, the UDP PPO ultimately claims liability rests with the state. Next slide, please. In this slide, I've presented the proposals ranked according to population impacts with the numbers besides them. The preventive excluding preventive visits from annual plan maximum could really benefit almost everybody. It certainly would reach the people who have not had a preventive visit in the prior year, but also for folks whose preventive visit counted against their annual plan maximum. The benefit would be freeing up some monies that could be used for more extensive services as needed. So the benefit is the broadest there. The composite number is based on composite fillings over all fillings. The incentive plan is based on the number of people who had class 2, class 3, or TMJ services, but did not actually have a class 1 preventive visit. Eliminating the children's deductible, as I said, is removing the deductible for kids up to age 15. Deductibles apply not to preventive services. They only apply to class 2, which is fillings, class 3, crowns, bridges, etc., and TMJ services. And the details on utilization and the numbers are contained in the appendix. Next slide, please.
Ellen, before you move on, I want to bring up a point that was asked at the sub-board. Just like to be as transparent as possible, and I'm at least 99% sure I haven't said this to this board yet. There was a question at sub about the 79% and 246,000 members that are impacted by preventive services and some nuances with that number. So that 79% represents two types of people. Individuals who literally would have less money coming out of their pocket, those people who are already hitting the plan maximum, or we estimated within $250 of the plan maximum, because that's typically individuals who might, when they got those services, would then reach their plan maximum. There's only about 4-ish% of the population that literally has hit their plan maximum, and another 8 to 10% that are within $250 of that plan maximum. So about 14-15% are people who literally could see a difference in their pocketbook, so to speak. The rest of this population that is being counted as 80% are people who are getting preventive services. And one of the pieces that I hope you remember Ellen presenting on the annual plan maximum is that in dental, we think about preventive services very differently than we do in medical. In medical, when you get a preventive service, I think we've ingrained in most people's health literacy psyche that when it's preventive, you don't think about any of the costs in any way, shape, or form. But here in dental, when you get preventive, it does count against you in your annual plan maximum expenditure, at least as is currently designed in a very specific proposal that Ellen has brought to you to change. And so when you go for a preventive service, you get an explanation of benefits. You see an incremental portion of your plan maximum has been spent for that service. And if we can eliminate that out of people's psyche, and we can really get to preventive services, absolutely free, there's nothing counted against you in any way, shape, or form, that will hopefully change the behavioral economics of how people interact with their dental benefits. And so we see that sea change on the way people perceive and enact their benefits as a positive improvement for that part of the population. But I didn't want people to walk away and think that 79% of people will see a difference in their pocketbook. It's a much smaller piece that will actually see different dollars not taken out of their pocketbook, but it's that experience they have with benefits and the way they think about preventive services and breaking down some of those barriers that mentally might prevent somebody from seeking those services because they're just unsure of what that cost will be and how it relates to the plan maximum. No matter how many times they have or haven't had a dental benefit, that experience of knowing that it has a cost that counts against you versus just eliminating that like we have in medical, that's why we included the entire population of people who have had preventive services in a year. So just wanted to be very clear because I thought it was a very astute point asked by a sub-board member if we were saying everybody was saving money literally. No, it's not that 79% of people will have more dollars in their pocket. That's probably more like 10 to 15%, but it's the experience everybody has with this type of benefit. Very good point brought up by Seb that I wanted to share here. Back to you, Ellen.
Thank you, Dave, for that clarification. On this slide, we're talking about the premium impacts, and it's reversed. It's from lowest to highest. And you will note that there's a difference between the PEB program and the SEB program, and that has to do with the demographics of the two populations. But I want to point out also how the Crown coverage that we discussed earlier fits into this chart. At the lowest level, the Crown coverage would be probably the fourth line on this, and at any other level, it's the bottom line, the highest impact. And the SEB employees experience the WEA coverage at the very bottom of the chart, again with the highest impact, but that was subject to visits in the prior year because it was part of the incentive plan. So generally speaking, between the fourth and fifth lines is where the Crown coverage would come in. The difference between, on the third line, between PEB and SEB has to do, again, with the demographics and the utilization within the programs. Dave, do you have anything to add to this?
Not at this point. Thanks, Ella.
Okay. Are there any questions? Okay. Next slide, please. So when we presented, is it just a week ago, to the SEB board, generally what we heard is that the priority should be on the incentive plan. Again, most of these employees had been participating in the WEA type program and are very concerned that they don't have an incentive plan anymore. I do want to point out the incentive plan that we have proposed is still different than the incentive plan that WEA had because the percentages are different. And they also had an agreement that there should be an increase in Crown coverage for some of the very reasons that Elliot pointed out here. You know, Crowns do wear out eventually, and as the population ages, there's more need for Crowns, and the average age in SEB is pretty close to PEB, in the late 40s, I understand. We did have a discussion about the likelihood that not everything would receive funding, and this was something that we had built into the original design of presenting different options, so that if the legislature could not fully fund everything, there would be an ability to sort of slice and dice and figure out ways to do things. And then we had a discussion about equity, and that adult dentistry in Medicaid is subject to fluctuating funding and is not always covered. So there's still questions about, you know, if we pull back, if we don't fund everything, we still have better benefits. We were also asked about the prevalence of non-duplication clauses. Let me explain what a non-duplication clause is. It's something that we do have in all of the dental contracts. What it says is if you have coverage from another insurance and you also have PEB insurance, your plan will never pay more than it would have paid if it were the primary plan. So how this works out in reality is if somebody had a plan that paid, let's say, 90% of filling costs, and there was 10% that was left unpaid, and they had double coverage, and they came to PEB and said, I would like the plan to pay the 10% that's not covered, the plan would say no, because you've already gotten more coverage than we would pay if we were primary, so there's nothing left. If, on the other hand, the original plan had, let's say, 70% coverage and our plan for fillings, and our plan covers 80% coverage for fillings, there would be 10% that could be accessed through double coverage. So that's the non-duplication clause. What we found out is in Delta's book of business, overwhelmingly, it's about 89% of plans have a non-duplication clause. But interestingly enough, in their larger employers, which is anybody with more than 10,000 employees, it's only about 40% of the plans that have non-duplication. Just a variation on this, Boeing has a non-duplication for 2 Boeing employees. So they allow duplication if it's an outside employer, but not if it's the same employer.
Ellen, I want to add at least 2 more things about the subboard meeting. The first is to help people understand the tenor of the conversation around the incentive plan by the subboard. They too agreed with the general theme of promoting preventive services, and there were some specific comments that highlight that the school employee experience pre-PEB with the incentive plan design viewed that as encouraging preventive services, because by getting preventive services, there was a lower cost share for more costly services if they were ultimately needed. So, that's not the same type of comment that I heard here at the PEB board. And I just wanted to draw attention to how the sub board members, particularly those who are school employees themselves, were highlighting that the school employees perceive that incentive plan design as a way to encourage preventive services. So just wanted to shine a little light on that in particular, because that's a different context that I had heard here at the PEB board, and just wanted to draw that attention. The second piece I was thinking about is, we've described this as, a low likelihood of receiving full funding, or what would you pick among this if you could only have, 1 or 2 things. But I do want to be very clear that there's no guarantee that any of it will be picked up during the budgetary processes. Yes, it's only a very finite, small, fraction of a percentage point of the budget, but there are many competing things. And even last week when when Allison Polson brought up comments about the fluctuating funding of Medicaid adult dentistry, how sometimes there are points in our state's history where children's Medicaid dental has been prioritized, but adult dental has been significantly cut and has waxed and waned at its level of funding and even existence. The legislature and governor's office could say, no, we want to invest more. We want to invest in dental, but we want to invest in Medicaid, not our employer compensation program. So I don't want anybody in this entire conversation to assume that there will be a benefit change that is funded, because we have had, over the history of the PEB program, decision packages that have been put up that have not been picked up. The LTD benefit being a very recent example of one. So please don't take away from these conversations that there is a guaranteed change in the Uniform Dental Plan as early as 2024. This is all about presenting the arguments and the prioritization and interest of these benefits, but it is absolutely not guaranteed that even any part of this would ultimately be picked up in a budget. So just wanted to, I realize our language may have been interpreted as like, oh, you're not going to get everything, but I also want to be clear, we all might get nothing out of this benefit proposal in this cycle. And, some of that would be policy decisions, and some of that could just be the economic circumstances of the state. You could have the best policy reasons in the world that everybody agrees on, and sometimes you just don't have the dollar. And that's just the reality. It just depends sometimes on the economic circumstances of the state. So, Elliot, I see you have a question.
It's not really a question. I'm grateful for your comment. However, I do find that sometimes it takes years. What is it? There's nothing more important than an idea whose time has happened. And I think if we don't throw it out, when do you start? And they can come back to it another time, like the Drug Affordability Board was not a new idea when it passed this legislative session. So that's all I'm saying. It's certainly worth a try, but you sometimes often have to look at the long run. And I think it's showing your leadership, at least getting the idea out there.
Absolutely, Elliot. Yep, absolutely.
Thank you for that, Elliot. And Dave, your summary is spot on. And I think the board is very aware that this is just for discussion purposes and we're not taking any action. Okay, Ellen, back to you.
One more slide.
I knew there was one more slide.
Next slide, please. So we did share with Seb the feedback from the PEB board meeting. And the only thing I want to add here is since the last meeting, we found out that King County has extended to county employees coverage for composite fillings for posterior teeth. And that's as of January 1, 2022. So lots of people are thinking about this. Next slide, please. And again, you know, we talked about with the SEB board, the concerns that had come up from the PEB board. Next slide, please. So again, we want to be sure that we're focusing on the correct piece of this and want to ask if anything should be dropped or anything should be ranked higher and why. Next slide, please. For the next steps, we are still gathering stakeholder input from PEB and SEB labor organizations, retiree groups. We're going to look at comparison with other benefit enhancements, as Dave has so eloquently discussed, and then put together the decision package. Just a reminder that Tanya Duell in January at the board retreat will go over the decision packages that are included in the governor's budget. So if we can go back one slide and leave that up for the discussion and open it up to questions.
Thank you for that. And I see Harry's hand is up. Harry, go ahead.
Yeah, thanks, Sue. I don't want to complicate anything more than it already is. It came to my thinking that would there be a possibility to have a high-low option? I mean, we have so many different variations of the medical plans. I guess one of the obstacles to having a high-low, if you will, would be the dental for employees. The premium is 100% paid, and to differentiate that out, would it be possible? I don't know what the union slots would be, but it would be possible for employees to voluntarily opt in or take a higher plan that would cover additional things like 60% for crowns or some of the other various proposals that we've seen. I'll just park that one on the side. It's just a thought. But as far as my views, I've said before, and I say again, I'm not in favor of the incentive plan. I'm in favor of incentives, but I think it's targeting the wrong people. As far as I'm concerned, I think the composite is a real strong proposal. I think the incentive is a strong proposal. The inclusion of the preventive visit annual day is pretty not very costly, and it can probably get some attention. And beyond that, you know, the crown, I'd like to see the crown fit in there somewhere if it could. And so I guess those are my thoughts.
Yeah, Harry, I just have one response about your question, sort of about a two-tiered option. It's like you're reading my mind and thinking about strategy in the future. I'm always trying to think about what the next type of proposal could be if the first proposal doesn't go anywhere. And you can look to hopefully my leadership on the LTD 3-year conversation. We tried, you know, door number 1, tried door number 2. Those doors didn't work out, so we tried door number 3. The very option that you've described is something else that you know could be looked at. But you are correct in your inference that would require collective bargaining impact given the language of the current collective bargaining agreement. So that's not any sort of short-term option, but it's certainly something that could be evaluated and again would need to have a collective bargaining impact conversation as well. So certainly something that at least within the realm of possibility, but an iterative other proposal that could, be down the road if something like this addition to the employer fully funded benefit doesn't gain traction from a budget standpoint. So reading my mind to the future world, parallel world. Ellie, do you have a question?
I just have a comment, of course. I think Carrie's idea is great when it applies to the senior plan. If it's self-paid, give them an option for, well, I don't want to say Cadillac, I'm dating myself, a Tesla and a Chevy plan. Maybe they can't afford the high end. Maybe some people can't, but at least they can get a 50% and someone else can get an 80%, have it a rising scale on what their options are because they're self-paying and you don't have to bring it to the legislature for funding, from what I understand, but I may be totally wrong. So I think Harry's idea is great. I also, especially with respect to the preventive side to things, because again, I haven't done a study like Ellen. And by the way, Ellen, I would love copies of your studies. I love reading this stuff. So what I've seen is that seniors will often go without dental care when they retire because it costs them more for the medical benefits. So this would reach a group that's not being reached.
Dave, I'll just say that I think the emphasis on prevention is really significant. And I think I appreciate that is continuing to be the top priority. Scott, I see your hand up. You're next. And then Tom.
Yeah, I want to first say thank you, Ellen and team, for this great presentation and all of the work and the details. I know it was a lot of effort, obviously reconciling a lot of different stakeholders and a lot of different information into one area is no easy feat. So I would just want to say I appreciate that. So, we've had this discussion for a couple board meetings now about impact on these things, these considerations on equity. And I know that there have been some board members that have expressed concern about paying for something else for a population perhaps they represent that doesn't necessarily have, that's not impacted by that. The concept of equity and the idea that we are helping each other even if you don't benefit from something is a core component. I think it's a core component of the health insurance risk pool in general, and one in which I think I would ask my colleagues to be mindful that when we make decisions, whether we're talking about childcare dependence and their ability to have certain types of services at no cost, we be mindful of that the fundamental ideas of equity are helping people who may need that help when you yourself are not being positively impacted or perhaps having to provide money or other resources that you will not enjoy. So that's how I think about that. I appreciate the emphasis on preventative services. I think there's a lot of great work here, and I would like that to be ranked. I'm still, I'm not interested in this incentive plan. I still think it has significant equity concerns. And I would like to emphasize child and dependent care, just because we know the burden of child care gets pushed to the most marginalized groups, and things like child care tax credits, as well as dependent care and dependent care focused benefits really do help. Thank you.
At the risk of stating the obvious, I would say that I also agree with the previous speaker that eliminating the children's deductible is important. But if you have seniors paying for it, the other option and the preventive care, I don't see that hurting your argument to the state legislature to pony up some money for the little kids.
Tom, you're up next. Go ahead.
First of all, I'd like to make sure that I have a clear understanding of if we were to adopt all of these proposals as currently stated, would the active public employees and the active school employees see any effect on what they have to pay out of pocket?
So the out of pocket, which is what you pay above and beyond what the plan covers, with the annual plan maximum design, there's the potential that you'd have more monies available for higher cost services. All of this depends on utilization, Tom. So it's hard to predict, you know, any one person's use of dental services. The eliminating the child deductible would also lessen the burden on parents who are paying the deductible for higher services for their children up to age 15. So there'd be a reduction there.
And then my second question is for retirees. They are the ones that have to pay a monthly fee for their dental care. And were we to adopt the proposals, that could potentially raise the monthly rates up to $7 a month. Is that also correct?
That is correct.
So
that's justified, not crowns, though. If you added crowns, it would be even more.
Yeah, okay, right, not crowns. That would be the 250 to 5.
An additional 250 to 550, yeah.
Correct. Okay. So I know that I shared with some of you some research that I did, because I remember at our last conversation there was concern about the impact that on retirees, that the rates that they would be paying would be significantly greater. And so I actually have been following uniform dental rates for quite some time. I was intrigued by it quite a long time ago. I retired in 2001. And at that point, I was paying for uniform dental $23.43 a month. In 2010, there was a significant jump from $41.69 to $47.63. And since then, the rates have remained incredibly stable. But if you adjust for inflation, we actually were paying, in today's dollars, we were paying $62.80 a month as a retiree. And now, by comparison, we're paying $48.64. In fact, if you adjust for inflation, 2022 is the lowest it's been since 2003. So I think we're overly concerned about rates. Uniform dental has been, in my mind, one of the best best plans that we have on the market for anyone. I've had many dentists and hygienists also say the same thing. It's a great plan. It is an incredibly stable plan. And it seems to me that the incentive plan actually would strengthen it. At the same time, over time, we would not be paying what we have in the past when you adjust for inflation. So that's my point. Thank you.
Yeah, Tom, I think it's important, one thing to know about the stability of the rates in the uniform dental plan. It's directly, one of the direct relationships is the stability of the benefit design. There has not been a significant benefit design discussion on the uniform dental plan in easily 20 years. And when you have a very stable benefit design, which includes a capped maximum amount of coverage per member that has not been adjusted for even inflation, your plan liability is extraordinarily stable too. So there is a direct relationship between the stability of the benefits and the stability of the rate and the stability of the benefit design as it's existed. And maybe I've been overly cautious, but I go back to day 15 or 16 for me as the then acting director of the PEB division was the public comment period when we were discussing UMP Classic Medicare rates, and it very much has stuck with me in my entire tenure here as the leader of the PEB and now SEP program about the fixed income challenges of retirees. And so I did not want to come off or have the agency come off at all as insensitive to the asking of $5 to $7 per month in the self-pay population of retirees. But your points are really well taken that there has not been a substantial change. It is a robust plan. It is stable. And, if these changes were all made, we'd expect there to be, that transition to that new rate, but there'd be no reason to think that there wouldn't be equal strong stability for the most part within the rates just at the new benefit, based on the new benefit design piece. So your point's well taken. I did just want to highlight, part of my thinking every day when we're looking at benefit design pieces are those public comments that I heard loud and clear in the summer of 2017, and it's shaped the way I think about things that we bring to the board and ways that we look at policy proposals. So I really appreciate your and Elliot's perspectives about the dental benefit design, the robustness of it, the value of different proposals as it relates to the premium that a retiree would expect to see increase. Those are really important contexts in the big picture as we're trying to kind of grapple with the concerns that we regularly hear from retirees and want to be very cognizant and appropriately consider in the process. So just wanted to throw that out there. Elliot, I see you have another question or comment.
If we don't get off dental soon, I'm sorry, you'll be here all day. Two other things that I appreciate what Tom had to say. There is also now a new 3% COLA bill in for PERS 1 retirees. As you know, PERS 3 has a built-in, PERS 2 and 3 have built-in COLAs. And PERS 1 is going to go for another COLA this year. And they're really going to put on steam for a permanent COLA. And so that may be a factor as well. Social Security has a COLA as well.
All right. Thanks, Elliot. Just looking to see if there's any other questions or comments. As Elliot said, we'll be working on a decision package. We'll be including in the narrative of that decision package the general preferences of the two boards. There's not perfect alignment from the boards, and we'll highlight like I said, the preferences of both programs and kind of see where things kind of land on this conversation. Do appreciate the various perspectives. We don't anticipate bringing this topic back the rest of this board season, but you can expect that this work directly relates to the decision package work, which you'll hear about at the beginning of next board season as we're entering the next biennial budget process. So we appreciate all of your insights over the past couple of months. Sue had to step away for a brief moment, so if there's no other questions, we're going to transition to the next presentation, and I will introduce that for her. That is Beth Heston, who's here. Thank you, Ellen, as a senior account manager in the IRB division, and she's going to share results from the vision benefit survey that was completed earlier this year. And Beth's materials are behind tab number 4.
Good morning, Chair Birch in absentia, and Good morning to the members of the board. As Dave said, I'm Beth Heston. You've heard me speak before as one of the herb procurement managers, and you'll hear me again. But I'm here today as the senior account manager for the standalone vision contracts with Davis Vision, IMED, and MetLife Vision in PEBB. Next slide. Okay, I think we have the wrong presentation.
Beth, that looks like the one that we're.
Page 4.
We should be on slide 2. There we go. Thank you.
Oh, there we go. Sorry.
All right. Our objectives today are to share the results of our 2022 Vision Benefit Member Survey. We also want to discuss current vision benefits in the PEB and SEB programs. Then we want to have a benefit change discussion. And lastly, we want to explain how the decision package process affects possible benefit changes going forward. Next slide. We held a vision benefit survey earlier this year, and it was held from January 26, 2022 through February 11th, 2022. And I'm sure some of you are wondering why did we have a survey? Well, PEB has had a gap of several years since we've discussed our vision benefit. It's been about 15 years actually on the PEB board. Back in 2007, when we last talked about vision, we at that time implemented yearly eye exams. Previously, eye exams had only been every 2 years. And we introduced the $150 hardware allowance. On the SEB side, we have looked at vision more recently, obviously, when we were setting up the SEB program. And at that time, our focus was on trying to reduce benefit disruption to the SEB population. So we were trying to find a solution that matched what most school districts had, and that was a standalone vision carrier to offer their benefit. Next slide. According to Vision magazine online, 75% of adults need some form of vision correction, but not all of them get it. So we sat down to talk about our vision survey with the goal in mind that we wanted to get opinions of our members regarding what was most important to them. And we also wanted to keep a survey. We know from experience that the fewer questions on the survey, the more likely members are to participate in the survey. So a survey that took the least amount of time would be targeted for the information that we were looking for. So additionally, we wanted to touch base with members and learn what they would like to have changed about their existing benefit coverage. Our internal teams had lots of anecdotal. As you can see, I'm a user of the hardware benefit, and many of us were. So we had our own anecdotal experiences, but we wanted to know about people out where we don't get to talk to them. How were those experiences going for them, and how did they feel about their coverage? We also wanted to get information, concrete, measurable information about which portions of the benefit were most important to our members. And also, how much are they spending out of pocket on the benefit? Next slide. So we created an online tool. We brainstormed questions with a group of internal subject matter experts, and there were lots of questions. we had to work to narrow down that list of questions that we most needed answered. Again, trying to make the survey as short as possible. We knew, as I said, we'd attract more participants the fewer questions we had. And I believe that we selected the best questions to get to our targeted responses. So we asked people, how are you eligible, so that we could put them in buckets according to which program they're in. Which parts of the benefit do you currently use? How satisfied are you with your benefits? What's the most important portion of your benefit? And what benefit enhancements would be most important to you? And lastly, how much do you spend yearly on vision? With the help of our communications team, we designed a communications plan so that we could get the word out to as many potential participants as possible. We use our outreach and training section to form and distribute emails that could be forwarded to workers through the email site. We reached out to our retiree contacts in the retiree outreach group. And we also posted on the website to draw attention to the survey. And we promised them that it's short, but it's very important. So after the survey closed, we took an enormous amount of data that we got. In fact, it was so big, it nearly broke our data analyst's laptop. And we analyzed those results and quantified the answers to get the most accurate results. So let's jump in. Next slide, please. The first question was, of which PEBB program are you a member? You can see that we had 22,645 total participants. Of those, 13,400 were PEBB, and the other 9,212 were SEB. Now, of course, that led us to question, since PEBB is the bigger program, is there going to be, a disparity in the responses, or is there going to be a proportional response? And what we found was that while PEBB had a 3.5% response rate, SEB had a 3.4% response rate. So they were very close to the same. And what we actually figured out after we talked about it was the only probable bias in the numbers is that only people who use the benefits are likely to participate and respond to the survey. Okay, next slide. This slide shows the result of our question regarding what type of hardware people use. And one thing I want to point out is that participants could check more than one box. So for instance, I wear eyeglasses, but I also wear contacts sometimes. So I was able to check 2 boxes. And I have prescription sunglasses, so I was able to check 3 boxes. Other participants could theoretically have checked all of the boxes. The survey I quoted earlier from the online source said that 75% of people needing vision correction, 64% of those folks wear glasses. And nationally, only about 11% of people report wearing contacts. However, you'll see that our results were a lot higher. Looks like about 35.5% or 33.5% of our participants are wearing contacts. Do I have any questions? Next slide, please. Okay, this slide gives the results for how satisfied are you with your current vision plan. And you can see that the response rates were sort of all over the board. So we looked at that data and we decided that if we think about the answer we want to see, we certainly would want to be 6 or above on this survey, with 1 being very unsatisfied and 10 being very satisfied. We would like everybody to be less than ambivalent about the plan. And that 6 or above was 43% on PEB, but it was only 39% on SEB. The people who said they were neither satisfied nor dissatisfied, so the ambivalent vote, was 15% on both plans proportionally, even though there's a difference here in the size of that. Proportionally, it was 15%. And then the number of people who were not satisfied, to various degrees, for PEB was 37%, and for SEB was 41%. Now, we did have some folks who said, about 925 folks who said this wasn't an applicable question for them. But obviously, we see that we want people to be more satisfied with their vision benefit. Next slide, please. This question asked people to rank enhancements in order and preference. Now, as you know, most prescriptions start out with a basic single lens, single reflex lens. And then many of us ask for enhancements to be made on those lenses. And I want to talk a little bit about the way these are discussed, because there's a little bit of term of art going on here. Lots of people think they have transition lenses, but in actuality, what they have is progressive lenses. Progressive lenses are the bi and trifocals with or without lines that offer you multiple focal points for your eyes in the same pair of glasses, the same set of lenses. Transition lenses are the lenses that have the photochromatic elements in them that respond to the light that is available in your environment. And so they'll darken or lighten as that lighting changes. So I wanted to be clear about that. And I think for most of us, we see that progressive lenses are a big, important enhancement to lenses. Part of that, of course, has to do, as Ellen mentioned earlier, the age range in both PEB and SEB is not that big. PEB has a standing age, average age of about 49, and SEB has an average age of 46. So all of us are starting to have needs for multiple focal points in our glasses. The next biggest, the next highest ranking scored enhancement was the non-glare lenses. And we know that that enhances our ability to drive with our glasses, to work on the computer with our glasses, all of those things where we could have our vision interfered with by glare. So that was also a very important enhancement. Next, polycarbonate lenses. And those of you like me who have very complex prescriptions, basically I'm blind as a bat. And so my prescription means that if it were regular lenses, my lenses would be very thick. But a polycarbonate lens is a lightweight material that allows you to have the same correction, but it doesn't weigh as much. So my glasses will stay up on my nose. And lots of people wanted polycarbonate lenses as an enhancement. The next biggest category was blue light filtering glasses. And if you're not familiar with these are specifically for using computers. They inhibit the blue light that causes a lot of eye strain and a lot of fatigue in your eyes. Next on the ranking was the transition lenses. And again, as I said, those are the ones with the photochromatic changes. And lastly were tinted lenses. And tinted lenses are just simply as it says, tinted for various purposes. Most of us think of them as sunglasses. Right. Next slide. All right, this probably was truly the money question. Our final question of the survey was, how much do you spend yearly out of pocket? So that means beyond what's covered for your vision plan. And so we have the categories here, $0 to $150 above what's covered, $151 to $300 above what's covered, and then going upwards to 601 over. And we had people in every category, but the bulk of our population fell in the 300 and under. And again, there are probably folks on there that spent $0, but we all know how expensive glasses are. And so we see that lots of people are spending $300 a year when their benefit only reimburses them every 2 years. All right, I'm going to pause here because the next set of slides goes into changes gears. Are there any questions about any of the survey results?
I'm not seeing any hands.
Okay, well then we'll move on. Next slide, please. All right, I want to talk about the two plans because some of you may be very familiar with the PEB plan and not know anything at all about the SEB plan. Basically, the first difference between these two plans is that this PEB benefit is embedded versus a SEB plan that is standalone. And that means that the PEB vision is offered through PEB medical plans. It's part of your plan. You go to your medical provider, your medical plan offices. If you're in Kaiser, you go to a Kaiser provider. You go to Kaiser, can't remember, it's their vision optical department. I can't remember what it's called. If you're on UMP, you pick someone who's in your network and you get your exam with them and they accept your insurance on the PPO. Okay. With the SEB vision, they go completely outside of their medical plan. They go to a standalone plan offered by Davis Vision, iMed, or MetLife, and they seek out a provider that takes that plan, and that's where they get their vision covered. The reason that we went this way, as I said before, was because most school districts had a standalone vision plan. The PEB plan being embedded has been that way since PEB first started in 1977, and it hasn't been changed much. It has only been changed, only been changed when the medical plans made some change to clinical criteria or common practices. There have been very few occasions, looking back over the history of the board, where the board has intervened to do any changes to our vision benefit. Right. The next change to the vision benefit, or the next differences in the benefits, are the way they're administered. PEB vision is paid through employee premiums, as well as the employer contributions. So it's the 85-15 split. Employees pay a portion of their medical premium that goes towards their vision. On SEB, the standalone vision premium is 100% employer paid. Next slide.
I will highlight for the PEB board that in the PEB collective bargaining agreement, if a standalone vision benefit is established, then the premium would transition to 100% employer paid. So that has already been, choose your own adventure book, if you will. Both versions exist in the collective bargaining agreement. And if there were a change to a standalone vision, it's already, the impacts of that have already been bargained, should that ever happen.
Thank you, Dave. The other difference between these, between the plans and the programs are that the PEB obviously uses the medical plan network, while the subvision carriers have different networks established in the areas of the state that they cover. And they don't all cover the same areas, though we did work really hard to get as complete a coverage as possible in SEB by those 3 carriers that were chosen. The
Beth,
one, I'm sorry.
Beth, Tom has his hand up before you continue on.
Thank
Go
you.
ahead, Tom.
Yeah, I just want to make sure, Beth, that I understand this. So if I'm a member of SEB, do I have the option to not have vision care?
Only if you don't seek it. It's part of the benefit package that's paid by your employer.
Mm-hmm.
So you cannot opt out. It's like dental.
Okay.
That's exactly how it works, is exactly like dental. You don't have to use it, but you can't get rid of it.
Okay, so I'm going to pay for it no matter what.
Well, no, you're not going to pay for it. Your employer's going to pay for it.
Oh, okay, that's right. Yeah, okay. Thank you.
Yep, sure thing. All right, so those were talking about differences. Now let's talk about the way they align. Both PEB and SEB have the same annual allowances. We have annual eye exams, and then we have frames and lenses or contact lenses covered every 2 years. Now, in PEB, that's that depends on your medical plan's count. So you get every 2 years according to what's in their system. But for SEB, those that reset comes on even years. So they started in 2020 and it reset in 2022. However, if you were hired in 2021 and you used your benefit, you could get lenses again in 2022 because the allowance had reset. However, you would then not be able to get contacts or glasses again until 2024. Does that make sense? Okay. And the $150 in-network allowance for hardware is the same on both plans. Next slide, please. So we have come before you today with some possible changes to the ERB benefit. First of all, we could choose to embed the vision benefit in the medical plans for both programs. This would maintain one-stop shopping for lots of folks. You know, people who are on our fully insured carriers would be able to seek medical and vision in the same building usually. They wouldn't have to search for a provider because there would be one or two available to them within their medical facility. And there would be no need to seek select another vision carrier. So they just pick it when they pick their plan. Some folks see this as a whole person sort of care because the vision results are in the electronic health record and are shared with your other providers. But it would be a big disruption to the SEB population because they are used to having this standalone vision benefit. And also there would be administrative issues that would have to be solved because the payment is different in SEB than PEB. Again, they're 100% employer paid. All right. The next possibility would be to choose to offer both programs' benefits through the standalone vision plans. And this would enable members to use their benefit to suit them. They might be able to find a way to make the $150 allowance go further. For instance, they could find a provider who doesn't charge as much for the exam and order their lenses online. So their $150 allowance would go further. We could also introduce a self-insured uniform vision plan to offer alongside other standalone vision plans. And that would reduce some of the administrative costs. Okay, but again, the difference would be that we have this calculated tier rate average 85-15 split in PEB versus the fully employer paid in SEB. And as Dave pointed out, if we go to the standalone, it's already bargained that PEB would move to fully employer paid. Any questions about those options? Okay, I don't see any hands up. Next slide, please. All right, here's our board timeline. I've introduced the vision points of discussion for you, give you time to mull over it, and we will come back to you in the June board meeting, one of the June board meetings with utilization data and potential costs for either option. And then during July, we hope that the board will have a discussion about what their consensus is for moving forward. Next slide. The remaining benefit cycle, the impacts, summer and fall of 2022, we will introduce a budget decision package. In December of 2022, those budget proposals will be finalized by the governor and released in his budget. In spring of 2023, a biennial budget for fiscal year 2023 through 2025 will be finalized by the legislature. And we have stated that for the benefit change to be introduced, we're probably looking at not 24, but 25, because there would, depending on how things go, there would need to be a procurement and implementation. So that gives us lots of runway to get the plan set up. Next slide. All right, other possible benefit changes. Were there changes not suggested here that you would like to see? And are there topics that you would like me to further research for future presentations?
Harry, I see your hand up, and then next, Elliot. Harry, you're muted.
Thank you, Chair Birch, for helping me to get unmuted and for recognizing me. But seriously, I've been advocating for a standalone or a carve out for some time, so I'm glad to see. And one of the good things I saw that potentially coming out of the SEB plans was that those negotiations would have already been done, and there's could be an opportunity if the board and other decision makers saw fit to go to a standalone, that there could be a vehicle. But what I'd like to, so that's sort of where I would like to see us headed in the discussion. But along those lines, I do have a question. I guess I'd need some help from Beth or others moving forward. Would be if we were to move from embedded to a carve out or a standalone, that 15% that the state employee is contributing now, in essence, would have to be made up by the state, because it would have to be 100% funded. So I guess the question would be, what kind of dollar value would that require, and how would that affect the funding rate? Would we be, in essence, having to give up something else in the medical or the dental? So that's, I guess, a question I'd like addressed at one of the future presentations. Thank you.
Thank you, Harry.
That'll definitely be in the future piece, and that is the cost of a decision package right there, that 15% incremental increase. So, yep, that is definitely on the radar. Again, Harry, you're right in my strategy mind today. So, definitely on the radar to bring to the board.
Elliot?
Yes, there may be some confusion on my part here. I'm not sure how the covered providers were picked by VSP. And my question related to that is the problem then of not liking the ones that are preferred would be resolved by a standalone program?
Not necessarily.
Okay.
The provider networks would be different under standalone. Currently, Regents, our TPA, has VSP as their network.
Right.
But IMED and Davis and MetLife offer slightly different networks.
Okay.
And so it would depend on where you lived and how many providers in your area were participating in those networks. So you could, under a standalone, you could find a different provider from one of the other vision plans and choose that vision plan. Because we would keep the allowances aligned, but the member would have to be a little more savvy, perhaps, about choosing the provider and choosing where to use their hardware allowance.
And it could be that you might not be with a particular provider who's aligned with any of those that are offered.
It might happen, yes.
Elliot, this piece that I'm about to add might help a little bit with that. So by maybe sheer coincidence, VSP is the network for the Uniform Medical Plan in PEB. And so the most prolific membership within the PEB program in the PPO population, obviously. In the STEP program, we do have Davis, IMED, and MetLife. MetLife has the majority membership in the STEP program, and the backbone of their network is the same VSP network, but MetLife has additional wraparound providers. So for the most part, somebody who is in PEB UMP will have a VSP provider that should be in MetLife's VSP, but they might also have additional choices.
Okay.
And we can do a little bit more on provider disruption, but the core of the UMP and the core of the MetLife benefit are very similar networks. It's just MetLife has a wrap network that is supplementing that same VSP.
That is helpful for me. I had somebody who wasn't affiliated with anybody. He was this little old guy, very cheap, did a terrific job, and just was his own dude and was not affiliated with anybody. Okay, that's good to know.
Beth and Dave, this is Sue. This might be a little off point, but I'm just wondering, since we have so much responsibility now with remote workers, would it make sense to push the blue or any of the eyewear that's related to computer eye strain over to kind of necessary tools to some other part, like the DES budget or some other part of how we think about things and get it out of our health benefit? I know it still has to be possible. I just think that that's something that we should probably look into to make sure, because it's a changing environment now that people are, I mean, I know for HCA, 85% of our folks are remote and Zooming all day long. So I'm just wondering and I see we have an optometrist raising their hand, but I'm wondering if we shouldn't just investigate that a little bit more.
Certainly can do that and get back to you soon.
And Sue, you're right. I do see the optometrist from the public. I don't know if you want to ask him to provide insights at public comment, or if his OD nature very well may be relevant for this topic. I don't know what your discretion, Chair Birch.
I am going to use the discretion because I'm sure he's seeing clients as well and say that Dr. Jeske, if you would like to comment on the conversation that's pertinent that we're having now, we would welcome that. And if it's not related or if it's a complaint to something else, we're going to push you back to public comment. If it's related, go ahead and open up your mic and identify yourself, please.
Hello, yes, Dr. Jeske, Tumwater Eye Center in Tumwater, Washington, 30-year provider in the state of Washington. Thank you for this, all the research and everything. I have to say, it's just wonderful to hear that and to see the research. So that is helpful for us. We are VSP providers, but the comments that are pertinent to what you're doing is really just threefold. Number one, if you ever want to have a provider that's in the area to be able to ask questions and get the provider perspective, I want to offer my services for that. Number two, I wanted to clarify the contact lens examination portion of the examinations that are now provided by SEBB and PEBB. Particularly the PEBB change, because I get a lot of comments from my patients about this. Prior to the 2021 change, the contact lens exam portion was actually covered yearly by the insurance. And after January 2021 change, the contact lens examination portion, or the fit of the contacts, is now only covered every 2 years. And so I have a lot of people that are asking about that and complaining about that. And I say, yes, that's a change that happened January 1st, 2021. And then the second thing is I heard a comment regarding the $150 allowance. And I just wanted to make sure that I clarified the $150 does not go toward the examination itself. The exam is covered, 0% copay for the PEBB BSP portion. The $150 is only for hardware. So it is only for glasses, lenses, or contact lenses. It's not for the exam. And so people can't really go to a different provider and have more available for the examination portion. It's only for the glasses and the contact lenses. And that's it.
Dr. Jeske, I do have to disagree. That $150 allowance is on the fully insured plans in PEB goes towards their contact lens fitting. So the contact lens, that's the first cut, basically is a charge for the contact lens fitting comes out of that hardware allowance. So it's just that is correct for UMP.
So we'll let you two take that up at offline so we can keep the board process going.
Yes,
thank you for that clarification.
But thank you, Beth, for your comments. But that is why I just want to make sure you really look at that, because the 150 historically has been for hardware only, and the fitting is a different section, and the exam is a different section. And that's it. Thank you so much for allowing me to comment. Appreciate all what you do, and thanks so much.
Yeah, we appreciate your comments.
And we will note that you've offered up to be a respondent if there are questions. Beth, I'm sure will be taking you up on that. Thank you. And Connie, please note for the record, so we'll just hold over Dr. Jeske's name just so we have that noted in the record for public comment. Okay, Beth or board members, are there changes not suggested here that you would like to see? And are there topics you would like her to present research on for future presentations? I think you've been so thorough, Beth, that I think everybody is saying we're good.
All right. Thank you. I think my next slide is just my question slide. So I will thank you for your time and your kind attention. Have a good day.
All right. We're going to move on to the next agenda item. This is the tax advantaged accounts procurement overview. Kelsey Peel is our senior account manager in the PEBB division, and she's going to present about our tax advantage benefits and an upcoming procurement related to these benefits. Her materials are behind tab 5. Kelsey, over to you.
All right. Good morning, Chair Birch and the members of the board. For the record, my name is Kelsey Pele, and I am a senior account manager in portfolio management and monitoring. And today I will be giving an overview of the tax advantage accounts procurement process. Next slide, please. Our objectives today are to first start off by recapping about the benefits, and then we will discuss the recent refinements that have been made. Then we will address the scope of work changes that have happened over the past couple of years. And lastly, we will walk through the FSA procurement details. And just to note, these benefits are authorized by HCA's cafeteria plan. So this presentation is just informational, and nothing in this update requires board action. Next slide, please. PEB employees can set aside pre-tax money from their paychecks to pay for eligible medical expenses. We currently offer 3 tax advantage benefits. We have the medical flexible spending arrangement, the medical FSA, the limited purpose FSA, and dependent care assistance program, DCAP. These benefits are administered by Navia Benefits Solutions located in Renton, Washington. And also our PEB members elect about $36 million out of their payroll deductions for these benefits each year. And as we know, these benefits have been extremely active and popular for our members to use. So the medical FSA reimburses qualified out-of-pocket medical expenses, including annual deductibles, co-pays, co-insurances, and other eligible expenses. Members can determine the annual contribution amount. They can choose to set aside a minimum amount of $120 up to an annual maximum contribution of $2,750 for the plan year 2022. The limited purpose FSA is a benefit intended for PEB members who are enrolled in a high deductible plan, such as our Consumer Directed Health Plan, the CHP plan. This allows the member to save more of their HSA funds for medical expenses, since the limited purpose FSA can only be used for eligible dental and vision expenses. PEB members can also choose to enroll into DCAP, Dependent Care Assistance Program. This operates the same as a medical FSA, but pays for eligible child care and elder care expenses. Next slide, please. So as we know, COVID-19 greatly impacted our healthcare system in 2020, which in turn impacted our members and their healthcare expenses. The IRS and Congress created flexibility and opportunities for states to allow relief for their members. So HCA created a limited open enrollment period in July 2020, where participants could prospectively adjust or end their contributions for the rest of the year up to the amount that they had already spent. And then in 2021, we also allowed participants the opportunity to prospectively change their elections in both DCAP and FSA 3 different times in the month of March, July, and September. The most recent refinement we have made that went into effect in 2022 were to change the FSA design by lowering the minimum elections by 50% from a minimum of $240 to $120. We also transitioned from a grace period to a carryover design and added the limited purpose FSA benefit. Next slide, please. So over the past couple of years, the scope of work has expanded for our tax advantage benefits. We added school employees to the existing Navia contract, which bolstered the utilization of these benefits. And then also the collective bargaining agreement, $250 benefit was established after the state and the public employee unions agreed to put into effect a $250 employer contribution to medical FSAs for PEB employees whose salary is less than $50,004 a year. And so effective January 1st, 2020, approximately 14,000 PEB employees a year are recipients who receive that $250 contribution. Next slide, please. And now for something a little different, HCA also administers a healthcare program for the COFA Islander population, which stands for Compact Free Association. I just want to call out here that PEB does not finance or subsidize this program. The COFA Islander population originates from the Republic of the Marshall Islands, the Federated States of Micronesia, or the Republic of Palau. But they currently reside in Washington State. In 2019, HCA began to use health benefit accounts, HBAs, which are initially access debit cards for Pacific Islanders who were not eligible for Apple Health. And these pay the monthly premiums and out-of-pocket costs for eligible COFA Islanders. Congress has since restored Medicaid eligibility to COFA Islanders, but we still need to keep this service for those who are eligible for Medicaid. COFA is run through Medicaid, and there really is no scope of impact here, but I want to highlight that this was a great opportunity for the agency to find creative solutions to use our commercial contracts to address access problems and bring IRB and Medicaid together to serve all of our populations in the state. Next slide, please. So given the significant changes and demands on the contract due to the expanded scope of work and experiencing a participation increase of 150% due to onboarding the subpopulation and the 250 medical FSA contribution for represented PEB employees, we decided to procure early in 2020. However, we canceled the procurement after we could not reach an agreement with the apparent successful bidder, the ASB, during contract negotiations. And it was at this time, since we had 2 more years on the existing Navia contract, we used this as an opportunity to renegotiate the current Navia rate, which resulted in over $300,000 in savings for the last 2 years of the contract. Next slide, please. The 2020 procurement the 2020 procurement process taught us many things for future procurements. First, in order to attract bidders who can manage the number of accounts we maintained, we learned we needed to set minimums for the number of accounts that bidders manage, both in their book of business and for their largest client. Second, we realized we needed to change how we present the possibility that IRB's HSA business could be added to the contract in the future. And a little background here, HCA's 20,000+ HSA accounts maintained for high deductible plan subscribers are currently managed by Health Equity, which is under contract not with HCA, but with our health carriers who offer high deductible plans. So with the idea of bringing the HSA business in-house in the future, we are again including that possibility in the request for proposal, the RFP, but ensuring that bidders base their administrative and cost proposals on the FSA business we're procuring for, not on HSA business that could come along later. And then third, we divided the bid review process into 2 different phases. First, we'll review the bidder's security and technical proposals to ensure that they can do the work and protect our members' health information. Once we know they can do that, then we'll review the rest of their proposal. If they can't pass that first phase, they'll be done. And this will ensure the reviewer's time isn't wasted as well. Next slide, please. In our 2022 procurement, we are currently drafting the request for proposal. And here is a list of services that are included. We have the medical FSA, the limited purpose FSA, the $250 CBA contribution for represented PEB employees, Dependent Care Assistance Program, DCAP, health benefit accounts for COFA, and any future HSA business. Next slide, please. I would also like to call out some important procurement dates we have tentatively scheduled. Like I mentioned before, we are currently drafting the request for proposal, and then we plan to issue the RFP out in late May. After we announce the apparent successful bidder, we will go through contract negotiations and implementation, and then the new contract plans to go into effect on January 1st, 2024. Next slide, please. All right, that concludes my presentation. I just want to thank you for listening, and if you have any questions, please feel free to ask me, or if there's anything later on, please don't hesitate to contact Dave, Connie, or I. Thank you.
Questions from board members? Not seeing any hands, Kelsey.
Right. Thank you so much.
All right. We're going to move on to our next agenda item, the Smart Health Update. So Kristen Stoimanoff, I'm butchering names today. I apologize, staff members. She is our Washington Wellness Program Manager, and Jenny Switzer, who is our Senior Account Manager, are going to bring the board up to date on Smart Health and an upcoming wellness procurement. Their materials are available behind tab number 6. Welcome, ladies. Over to the two of you. I'm not sure who's taking the lead. Kristen?
First, but I believe she might be suddenly having some technical issues, but let's give it a moment. And
I am available. I'm not having technical issues, but
maybe we could start with Jenny and then move back to the beginning with Kristen.
Okay.
Yeah. Why don't we start with Jenny, which would mean we will go ahead and move directly to slide number 5 to start off with, and we'll get some work with Kristen and then come back to do the first part. So Jenny, why don't you start for us? Thank you for going first.
Not a problem. All right. So good morning, Chair Birch and members of the board. My name is Jenny Switzer, and I'm a Senior Account Manager for the Uniform Medical Plan and the Contract Manager for the State Virtual Wellness Contract. I'll be providing information today on current and upcoming work that HCA is doing for wellness contract procurement. In prior board meetings, Tanya Dould highlighted a decision package that was submitted for upcoming procurements. This is an example of one of the procurements included in that approved decision package. No action is necessary from the board, but we felt it was important to keep you informed on the procurement activities that will be taking place. So as we move into the first slide here, I wanted to start the presentation by providing a bit of background information on how the state wellness program came into being. In October of 2013, the governor signed Executive Order 1306, which included a requirement that state and employee health and wellness steering committee be convened to work towards implementation of health and wellness changes for state employees. This committee was to be co-chaired by HCA and the Department of Health, and they were tasked with developing a comprehensive wellness program that included incentives for state employees. The basis for the need of the state wellness program is that when employees are offered educational tools to manage their wellness, HCA and PEB organizations can promote a healthier, more productive work environment. Additionally, research indicates that a wellness program can support reductions in healthcare costs, improve productivity, and increase employee retention. As a result of the work done by the Health and Wellness Committee, HCA initiated a competitive procurement to select a vendor that would meet the requirements of the executive order by offering a comprehensive wellness program that focused on physical, emotional, relational, and financial health, along with improving work-life balance. Limeade was selected at that time as the successful bidder from the procurement work, and HCA entered into a contract with them that could last up to 10 years. With the end of that contract nearing, HCA has begun the process to identify requirements to procure a virtual wellness vendor to meet the needs of our members. So on the next slide here, I've outlined some high-level wellness procurement goals. So to ensure that we select a vendor that provides value and the necessary wellness requirements to improve health and well-being, we developed these high-level goals that are expected of a successful bidder. Obviously, we have more drilled down specific technical and programmatic goals, but at a high level, we want to ensure the vendor and their product offering is a holistic program that supports employees in their physical, emotional, relational, and financial health and well-being, as well as promoting that healthy work-life balance, as I discussed on the last slide. The portal must encourage participants to complete a well-being assessment, also known as a health risk assessment. This information can be used to develop custom content to support the employee in making health and well-being progress in areas that they have indicated are areas of improvement. The activities, challenges, and resources within the offering must be targetable so that members can receive impactful information that is appropriate to each individual. This includes ensuring employees have access to resources that are available to them based on health plan, their organization, and member self-reported information through that well-being assessment. The portal must meet the Office of Cybersecurity requirements for data security and must meet accessibility standards to ensure an equitable experience for all members. On the next slide, I have an overview of our request for information timeline. So we decided that we wanted to better understand the virtual wellness offerings in the market prior to moving forward in a request for proposal or RFP. We felt that gaining this understanding would help us more in development of an RFP. As a result, we initiated the process to develop a request for information or RFI. We began development of the RFI in February of this year and posted it externally for responses in March. We used industry research along with knowledge of our current wellness program to develop the RFI. When RFI responses were received in March, an internal review committee comprised of members from contracts, benefit strategy design, and portfolio management and monitoring immediately began review of those submitted materials. We met with vendors that submitted materials to hear more about their offerings and to allow time for us to ask questions to better understand available programs. The written and verbal responses have proven to be extremely interesting and helpful in our development of the RFP. So in this next slide, now that the RFI has concluded, we began work on the RFP content. We're still developing the RFP timeline, so I don't have that specific information to provide to you today, but we are including technical and programmatic requirements in the RFP based on the knowledge of our current program, information gained during the RFI process, industry best practice information, and internal subject matter expertise, specifically surrounding information technology, contracting, security, and accessibility. After respondent information is received from bidders during the RFP process, HCA will score the materials based on a set of metrics that are still under development. Once the written materials and, if applicable, presentation materials are scored, HCA will announce an apparently successful bidder, which will initiate contract negotiations and implementation activities. The new wellness contract is anticipated to begin on January 1st of 2024. So that brings me to the end of my slides. Generally, we would open this up for questions for Kristen and or I, but if anybody has any questions specifically for me in this procurement process, please feel free to put those forward.
Thank you, Jenny. I am looking for hands and I am not seeing any. All right, let's move on to Kristen.
Go back to Kristen. I think she's all ready now.
All right, thank you, Jenny. Kristen, over to you. You're muted. You're texting us. You're having problems. We're reading. Yes, we're trying to. Okay.
Are you needing to call in from your phone, Kristen?
Yes. So board members, please just stand by.
Audio.
Stand by while we create a patch.
No worries.
Dave, this is really where we need that theme music, you know?
Yes, we did check Kristen's audio this morning, and at the beginning of the meeting, it was all fine. So it's just one of those quirks, but
One of those days.
she'll call in and we'll be off to the races.
We've got all those good derby. We're coming, we're what's the rich something, rich steaks. We're coming from behind.
Rich strike.
Rich strike. There we go. And Elliot, you had a good idea. We should all be standing up while we're just waiting a minute or two. Elliot's going to lead us in yoga or calisthenic stretches. I think Connie's smiling. I think I see Connie smiling under that mask.
When you get old, you have to move around.
Wisdom. Well, Dave?
I don't want to steal Kristen's thunder, but if needed, I could possibly fill in for her.
Yeah.
Why don't we get started?
Let's
here's
have
Kristen.
Jenny, let's have Jenny pinch hit, and I will supplement your pinch hitting, Jenny. And Kristen, don't get too disheartened. It's just one of those things. But Jenny, if you don't mind, and then I will pinch hit with you.
Okay, so give me just 1 second. I don't want to say that I wasn't prepared for this, but I was not prepared for this, so.
It's okay.
1 second. Okay, so let me get onto my notes that I have here. All right, well, good morning, Chair Birch and members of the board. My name is not Kristen Stoimanoff, but let's go ahead and walk through the information that she has worked so hard to put together. So the presentation on the Smart Health Update today is to share information with you about the upgrade to the new Smart Health experience that recently took place. And so some information about it: on April 12th, Limeade, which is our Smart Health vendor, officially moved us from their Limeade Classic platform to the upgraded Limeade One platform. We now have critical security enhancement of multi-factor authentication, which requires users to provide 2 or more pieces of evidence to verify their identity to get access to an app or digital resource. And people will continue to have access to activities that improve their well-being. And for those that access Smart Health on a mobile device, the look and experience is the same as it was on the website. This is different than it was in the Classic experience. With the Classic experience, it was a very different user experience between the website and the app, which caused some confusion and a little bit of member abrasion as they tried to navigate using both of those systems. And the usability of the site is a little different. It actually is a lot easier for members to find information about resources and benefits. There's actually a tab where people can go that's specific to resources that are for them in their health plan. So it's just easy access. It's a lot of routing to HCA pages, or if you're a Uniform member, it'll route you to your login for Uniform. It's a lot easier access. In the next slide here, we wanted to show some information about how we ensured that members had adequate knowledge of the upgrade experience. HCA and Limeade launched multiple communications before, during, and after the upgrade. Before the launch, all Smart Health users received an email from Smart Health, well, Limeade, in late March, giving them notice that this change was coming. We also worked with Limeade to create a toolkit for wellness coordinators. So at organizational or agency levels, there's wellness coordinators that do promotions for their organizations of the Smart Health portal. So those wellness coordinators received the toolkits that included a forwardable message that they could send to their employees, an article they could use for newsletters or other communications, and a flyer, which is pictured on the slide here. On launch day, which was the 12th of last month, all registered Smart Health users received an email from Limeade. All members who had signed up for communications through Gov Delivery also received an email via that way of receiving messaging. And we sent our wellness coordinators at the organizations a message that they could forward to their employees, notifying the employees that the launch was successful and they could now log in and experience the new Limeade One platform. So, and then additionally, shortly after the launch, we posted social media posts on Facebook, Instagram, and LinkedIn notifying members of the new experience and the access to the site. Additionally, 2 weeks after the launch, we sent another email to all Smart Health registered users that came from Limeade, reminding them that this new experience was available. There was a change to the app, so reminding users to go in and check out the new app. And then I know Kristen was going to also talk about how many people had signed into the Limeade One portal since the launch. I don't have that information, but I'm sure she can follow up with that.
I can provide a little bit of that insight. I'm aware of some of it, and so let's see. Since the I believe on launch day, or right around the launch day, so far, as of I believe the end of last week, we're at about 9,600 PEB members who have transitioned over. We have a total of about just under 12,000 total members between the two programs have transitioned and begun using the new platform. And we've also seen a couple hundred increase in new registered users who had never been part of the platform before. So we've been seeing a good transition over. I did want to highlight, and I don't think you said this part exactly, Jenny, when we had this transition to the new platform, there was a week of downtime for the system. And that's why there was such an extensive communication plan to alert members that if they tried to access the portal during that upgrade period, that they wouldn't be able to. And that also is the reason, when we did kind of a soft launch of the program this year, because we knew that there was going to be a cutover to this new platform at some point in the first part of the year. That ultimately landed on April 12th. And so now we're going to begin a kind of a more full court, typical press on communications and engagement. And that actually is transitioning to the next slide with one of the promotions that Jenny can talk about. So I did want to highlight that you might not have heard as much about Smart Health in the first 2-3 months of the year. That was a little bit deliberate, just as we knew that there was going to be a cutover piece. And now we're having our full grand opening for 2022. So Jenny, why don't you talk about that next piece?
Yeah, thanks, Dave. I got through all of that and it dawned on me that I didn't mention the downtime. So you and I are in sync. Thank you. So on the next slide, really this just shows one promotion that we're doing to help drive that engagement, because as Dave said, we did soft launch the portal earlier in the year. So we didn't have as many communications. We had a little bit more limited activities as far as plan specific activities, still hundreds of activities for people to complete, but not the full suite of targeted custom activities that we normally would have. And so since we are now jumping into the full swing of this launch of the Limeade One platform, We worked with Limeade. Kristen worked with Limeade to see what ways we could really promote the portal and make sure that people were engaging. And one of them was that Limeade purchased tickets to this Minnesota Lynx versus the Seattle Storm at no additional cost to HCA. And those are going to be available as something that people can win by participating in activities in the portal to help drive engagement. So we'll have some communications around that. We're also looking at other opportunities for promotion. So not everybody, me included, sorry, sports fans, but is super motivated by sporting events. So we're looking at what other promotions we can run as well, whether those are Discover passes or gift cards or whatever it would be that would get people engaged and interested in participating in the platform. Like Dave said, we are actually seeing really good participation and engagement rates since the launch. And it's not that people didn't have any access before or that their information restarted. With the launch of the upgrade, all of people's points that they had earned and activities that they had completed, those all rolled over into the launch. And so there was no break in people having to redo any of their well-being assessments or anything like that. But we just wanted to make sure that to, as heavily as we could without being annoying, promote the website. We found ways to do that that would hopefully encourage people and remind them, hey, this is here for you if you haven't been as engaged because we haven't promoted it as much. And so we're really excited about this opportunity to offer these tickets to members and look at other ways to promote the portal and engagement in it. So this brings us to the end of Kristen's presentation. Are there any questions that I can try to answer?
Jenny, I see Tom's hand is up. Tom, go ahead.
Yes, I am curious, when you did the request for information, how many vendors actually submitted ideas that you were able, and then you met with them, obviously. How many were there?
There were 13 vendors that submitted, that participated in the request for information. We only met with the first 10 vendors that submitted materials just because of time constraints. So it was on a first come, first serve basis, but it was a pretty good turnout for a request for information. We know that for the request for proposal, there are more than 13 vendors that have reached out as interested in that when we're ready for that.
Oh, okay. So that was going to be my next question is, if all of these people that originally contacted you, are they going to then follow through, or do you have to actually only end up with 2 or 3? So you answered my question, actually.
Well, and I mean, I answered it, but there's some if ands in there, right? So as we're developing the request for proposal, we're putting requirements in there that a successful bidder would need to meet as far as like security, accessibility, standard program requirements, things that we need the portal to be able to do. So to say that, more than that have reached out saying that they're interested doesn't mean that they actually will put it in, but it does. We were very delighted with the amount of vendors that responded to the RFI, which is generally a really good sign for RFPs as well.
Okay. All right. Thank you.
Other questions? Well, seeing none, I want to thank Jenny for pinch hitting. Kristen, we'll follow up with you, I'm sure, if other questions arise, and I know we'll hear from you in the future. I want to thank both of you. We really appreciate this prevention and wellness push that we remain committed to. So, all right. I think at this point, we'd like to go ahead and call for public comment. And if there's anyone on Zoom that would like to provide comments, or Connie, if you've got notification from anybody, I'd like to hear about that. Is there a list of speakers, Connie? I think that's a no, but I see Fred's hand just shot up. So Connie, I think I'm correct in saying that, no, you don't have a list of speakers. Would you, correct, okay. So at this point, I'd like to recognize Fred Yancey, because I see your hand signaling that you'd like to speak. And please click on your open mic and tell us who you are, and we welcome your comments.
Thank you, Chair Birch and members of the committee. My name is Fred Yancey. Speaking today on behalf of Washington State School Retirees Association. And if I get knocked off, so be it. I've been knocked off twice because of electrical issues. Quite the windstorm going on outside, so it may have accounted for the one young lady's absence on the meeting as well. But first of all, I'd just like to say I appreciate the sensitive remarks made by various members of the committee regarding retirees and the fact that they self-pay for these benefit costs. I've suggested during the SEB meeting that I think it might help if the members had rate sheets in front of them as well, so they can see the base rate that members are currently paying for insurance offerings. And even though some of these increases are modest, retirees live on relatively fixed incomes. And, a 3% COLA is not very much. A 5%, a little over 5% Social Security bump is not very much. And some of the older members, particularly Plan 1 members, don't get any COLA at all unless legislature approves it. So these, any rate impact potentially adversely affects not only the financial well-being of a senior, but also whether a senior will elect to have that coverage that we all think everybody needs. There's no question that preventative dental is important, preventative medical is important, and so forth. Mr. Bossi, I think your suggestion that they offer a high-low option is one way of, perhaps addressing this, this issue, rather than having to decide from a senior perspective whether to have insurance or not. At least they could have the choice to have, this insurance that has a little less coverage, or that insurance that has better coverage. With that in mind, I appreciate your time and I appreciate all the work that members of the committee do. So thank you very much.
Thank you, Fred. We will always take those compliments of gratitude. All right, others from the public that would like to comment, please signal by raising your virtual hand. We'll give it here another minute or so. And Connie, you will reflect that our optometrist, Dr. Jeske, spoke earlier.
Yes, I've got it.
Okay, I'm not seeing any other signals for public comment. So, board members, a few items of business. Our next meeting is going to be June 9th from 9 to 2 p.m. And Dave, if you would like to make any final comments or a preview about our next public meeting before we move into executive session, I would welcome that.
Yes, just briefly, at the next board meeting, we anticipate June is when we start to describe some of the potential benefit changes coming out of the medical plan procurement that could be in play as we head towards sharing the premiums and rates for the various plans. And June is also the month in which we now try to have the board address and pass the 2023 premiums for the Medicare plans. So that is the general tenor of the next meeting, is the introductory process that eventually leads into the non-Medicare rates in July, and the actual more formal process setting the plans and premiums for the Medicare population. So those are the main topics that can be expected.
Great, thank you, Dave. At this point, I would like to let members of the public know that the board is going into executive session pursuant to RCW 42.30.11011. The board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state-purchased healthcare services as provided in RCW 41.05.026. The executive session will conclude no later than 1:20 p.m. And Elliot, I see your hand raised. Let me just finish with this. I was going to suggest that board members that we take a 10-minute break while we transition into the executive session. And then we will, for the public that's listening in, we will be returning to our public meeting after the executive session to adjourn the meeting, but there will be no further presentations. So, Elliot, do you have a question or comment?
Mr. Yancey, I encourage you to get a permanent COLA for PEB1 members, and I encourage you to increase the COLA rates for the Plan 2 and Plan 3 members as well. I'm sure you will do so. Thank you.
All right, so we are now going to go into executive session. Board members, it is 11:42. I suggest that we return at 11:52 and go stretch, get something to drink, and we'll be moving into executive session. Thank you to the public who have listened in with us. And Dave and Connie, you're going to do your technological magic and beam us over.
Correct.
Yes.
Got it.